Welcome to a new episode of Medicine in 3 minutes. As usual, we go straight to the point. The subject is bravely made clear and often illustrated. Let's start. Today's topic is about Myasthenia Gravis. Myasthenia Gravis is an autoimmune disease. That means there is antibody against cholinergic receptor. The distribution follows a double peak, 20 to 30 and 40 to 60. The first peak, there is predominance of female sex. The second is the predominance of male. In the first group, we meet thymic hypoplasia. In the second group, we meet thymoma. A role of antibody in myasthenia gravis. 85% antibody are against acetylcholine receptor. These antibody are from the mast IgG, which cross the placenta. As a consequence, newborn can have muscular weakness. But 15% previously seronegative. Antibody against mask. How to identify the autoimmune role? Antibody from the patient injected into the animal to produce paralysis. If we reduce the activity of antibody patient by immunosuppressor, his condition improves. Plasmapheresis also can remove antibody from the patient. As a consequence, it leads to his improvement. Complement protein are special soluble protein present in our biological system. In healthy person, most of protein are produced in the liver and circulating in the blood. They have many functions among them. When antibody IgG or IgM bind with antigen fragment Fc, the fragment Fc become active in classical pathway with C1, C4, C2b, and C3b. They will cluster together as a pore which is inserted in a membrane. The permeability of membrane will be disturbed, like a drill machine that damage membrane and cell go to death, which makes special pathological. When membrane is lost, less fold and less crest membrane become simple. Morphological alteration of membrane, surface area of neuromuscular junction is reduced, density of receptor unit surface area is also reduced, distance between presynaptic and postsynaptic increase. The result is the reduction of neuromuscular transmission. Membrane becomes simple. Surface area of neurojunction is reduced. Density of receptor is reduced. And distance between presynaptic and postsynaptic increase. In myasthenia gravis, autoantibody against thymic abnormality. 10% of thymoma, most of them are benign but sometimes become malign. One of the treatments of myasthenia gravis is thymectomy, more common in old age and men. and the cells affected are epithelial, not T, not B cells. But 50% of thymic hyperplasia is most common in younger females, with the predominance of B cells, not T cells. Females that not have thymic hyperplasia have chance to suffer from other diseases like vitiligo, diabetes mellitus, Hashimoto thyroidite. The second mechanism is anti-mask protein autoantibody. There is no thymic abnormality. Clinical presentation: muscular weakness of voluntary muscle. It doesn't affect smooth muscle. One essential characteristic of this weakness is painless. It starts as insidious and increases gradually. There is some fluctuation, and with sustained effort, weakness rapidly worsens. The weakness worsens over the day, and cranial muscles are the most involved. Extraocular weakness with ptosis and diplopia. Difficulty to sit down or to get up. Unable to completely close the eye. Mass swallowing difficulty. Bulbar muscle medulla 9, 10, and 11 regarding to articulation, phonation, and swallowing. Difficulty showing, difficulty swallowing, and pharyngoesophageal articulate. Laryngeal muscles are responsible of phonation. Sound is produced and converted by tongue and lips, soft palate. In the case of Myasthenia Gravis, there is nasal twang, which is nasoline. And muscle of facial expression, there is sad myasthenic snarl. Then weakness spread over the body. It starts in top and goes down. Myasthenic crisis can affect respiratory muscle, which need artificial ventilation. One essential characteristic of the disease myasthenia is A before gait. In contrast, Lambert-Eaton gait before the A. Anticholinergic antibody develop generalized weakness. Anti-muscle antibody give focal weakness, but sensory system is normal. Deep tender reflex are normal. How to make a diagnostic? Auto-antibody, anticholinergic antibody, and anti-mask antibody. A repetitive stimulation of motor nerve for a specific muscle becomes gradually decreased, which take the appellation of decremental muscle response and repetitive stimulation. Now in that, for Lambert-Eaton, incremental response. When you do MRI, thymic tumor or thymic hyperplasia, we can use the Tensilon test as activating hydrophonium, which gives short-acting, anticholinesterasic drug weakness, patient improve. We can use also ice and eyelid to improve ptosis. How we treat myasthenia gravis? First line in management of anti-myasthenia gravis is anticholinesterase drug. Pyridostigmine, neostigmine. They inhibit the action of cholinesterase. With time, they lose their efficacy, reduce the production of antibody. Immunosuppressive, like cortisone, azathioprine, or cyclosporine. We can use also plasmapherese, which remove antibody out of circulation, and we can give intravenous immunoglobulin. We have to remove thymus, especially if there is thymoma. And avoid the drug predisposing to neuromuscular impairment, like gentamicin or tetracycline or others. Myasthenia versus Lambert-Eaton. Myasthenia starts in the A and go to the gate. In Lambert-Eaton, it starts in the gate and go to the A. Myasthenia gravis, look for thymoma. Lambert-Eaton, look for paraneoplastic small cell cancer. Myasthenia gravis, it becomes worse with the day and with the effort. Lambert-Eaton, it improves during the day and improves with effort. Thank you for watching this episode of Medicine in 3 minutes. Would you like to click the button like and subscribe? Your comments are very welcome. Thank you.